Dear Facebook Pure Urology viewers, today is something different. What I was thinking, we have finished 1 year, 2 months like that, daily presenting or alternate presenting surgical technique. Even though it was surgical technique in PowerPoint presentation, we were seeing some amount of theory. Naturally, webinars, we are fed up. To make it a little interesting, because this urology forum is more than 8,200 now. We thought because of the many requests from the people, we thought we will share a surgical technique without editing, not even 1 second without editing, focused on only few things. Like today we have selected puncture of the PCS, because every year nearly 300 urologists in India and very many urologists juniors will be coming. They may not get adequate chance to get trained. They may not be good in PCNL. They may not be good in all these surgeries. So if this point, for example, today we focused on puncture, tomorrow we'll focus on dilatation, some other day quilting of buccal mucosa, some other day angle stitch in pyeloplasty, some other day only bladder tunneling, like that, so that we'll have innumerable number of subdivisions, and that will create interest and the program will be going on and on. So with this, today Dr. Kukreja sir has already presented 2 times in our Pure. So without wasting time, I will directly introduce him without asking his personal history, because we have already shared that. So Dr. Kukreja sir, thank you once again for accepting the invitation. I know you are very good in prone PCNL puncture. In fact, today morning only recorded everything, and he is presenting without any editing. So PCNL puncture prone. So Dr. Kukreja is a consultant urologist at Eurocare Hospital Indore, a well-built, decent, self-made hospital with all facilities. MBBS MS from BJ Medical College Pune, DNB from MPUH Nadiad, a well-known prestigious institute of India, fellow World Endo-Urology Society, one of the favorite early project of Dr. Mahesh Desai sir, and also Dr. Kukreja is one of the favorite student of Mahesh Desai sir. Awarded HS Bhatt gold medal from past President of India Abdul Kalam, specialized in pediatric urology and reconstructive urology by taking interim training in Sick Kids, Toronto, Canada, Arezzo, Italy respectively. He has published many papers in national and international journals, experience of more than 5,000 PCNLs. He has series of more than 180 cases of pediatric PCNLs of children aged less than 12 years. He is often involved in world over to demonstrate live surgery. In fact, he came to our place also. I feel he has soft hands to identify the appropriate calyx and is my favorite for mini perk and laser and suction of the fragments. Our main focus is only puncture today. After that, fast forward, we can see the rest of the surgery, but focus is on puncture. Less discussion, more visual effect. Over to you, Rajesh sir. Thank you very much.
Thank you, Chandramohan. Thank you for the introduction. Am I audible very well?
Yes, sir. Sir, before you start the video, before you share the screen, tell only 2-3 important points which how you puncture, not theory, but today's case reference only before sharing the screen. Maybe I will ask you, number 1, you are favorite for only middle calyx or any calyx which is appropriate to the stone? Answer please.
Any calyx which is appropriate to the stone.
Yeah. Do you believe in anterior posterior calyx in prone PCNL?
Pardon?
Do you believe in anterior and posterior calyx puncture in PCNL prone?
Only in the middle calyx. I understand that concept.
Answer is over. Only middle calyx, anterior, posterior are there. Inferior calyx and superior calyx, no. Third question: when you are in, when you are seeing the RGP, do you puncture? Hello.
I am listening.
When you are puncturing any calyx in the inferior calyx and superior calyx, do you go laterally or you will have any tip and trick to select the calyx posterior? Some people say contrast will not be seen, faint shadow medially will be seen. Some people say air can be injected. Some people say medial calyx at the infundibular junction is best calyx, or some people say any calyx lateral you go and you can remove it. What is your gut feeling?
See, I basically, the first important thing you said, whatever you plan with a CT or whatever, the proper puncture will be planned intraoperatively when you do the RGP. So I
Correct.
don't bother much. I don't generally use air much unless I'm in a problem. So I
Correct.
don't use air much. I put contrast. What calyx is the lateral most and what calyx gives me a access to the peripheral part of the calyx, and it should be in straight line from the calyx to the pelvis to the PUJ and should give you access to the maximum stone burden. That is going to be
Okay.
my.
What safety line you keep in difficult cases not to injure the major renal vessel? Is it the infundibulum you will take as cutoff for your needle, or sometimes you go medial to it also?
You should always go to the tip of the calyx. Now, it's not possible that you go
Perfect.
through the fornix of the papilla always, but you should be as
Yeah.
peripheral as possible.
In superior calyceal puncture, up to what level you feel safe? About 12th rib or above 11th rib?
No, we go many
Prone
times. We go
PCNL.
many times. We go between 12th and 11th rib. Sometimes we also go between 10th and 11th. What is very important, if you see the puncture paper which was there on upper calyceal puncture, it is you should be lateral to the mid scapular line because the pleural
Okay.
reflection is lowest at the
So,
mid scapular line. So if you are lateral to the mid
lateral to the
scapular
mid
line,
scapular line. Lateral to the mid scapular line is the most important. Now, last question. In case if it is kidney is high, do you don't mind in entering through the above the 12th rib and make a little oblique tract towards the up, because every time it is not possible coming from top to bottom. You can go a little obliquely from the above the 12th rib lateral to the mid scapular line and then enter the lateral part of the calyx. Is it okay?
it's okay, but I don't like a too
Okay.
much of a oblique track. Too much oblique track bleeds. It is better you go higher up. It's better you go higher up.
Better you go to
And if
higher
you
up.
feel your
Now,
puncture, so you plan, if you feel your puncture is going to be between the 10th and 11th or between 11th and 12th, always give GA for such patients. Always give GA. Don't do it in spinal then.
right. So now we will go for the today's case, what you have recorded with cell phone and what was the case briefly. But thing is, we have to finish in 15 to 25 minutes of time, sir. This is the role model presentation today, please.
No problem. I'll present and you can stop me whenever you want. I actually
No,
finished the
no
entire case in
stopping.
25
No
minutes.
stopping. You keep explaining. That's all. No stopping. It is
I
unedited
keep
as if
explaining.
it is a live sample.
No, no, the entire dilatation and the puncture, everything, the planning, the puncture is all unedited. I have not removed even 1 second
Okay,
out of
sir.
that. Okay.
Go ahead,
So
sir. Go ahead, sir. Thank you.
I'll start with this presentation. This is our OR setup. Just for I have everything. We have the ultrasound, we have the fluoroscopy, and we have the OR1, everything. What normal orientation is, I prefer to have the CM view or the ultrasound view, whatever I'm using for puncture, towards the head end of the patient. And I like to have the endo monitor towards the foot end of the patient. It is very important for me for the three-dimensional orientation of my brain. If I have the CM picture on the foot end, I sometimes get lost. So you have to plan what is correct for the puncture. Just
Okay,
in
start.
one slide, I'll show you this. This patient had presented to us around 4 days back with a creatine of 5.8 and a potassium of 5.7. So he had multiple left lower ureteric stones and an impacted stone at the right PUJ. So what we did, we put left side, we did the primary ureteroscopy and put a stent. And right side, we just managed to push the stone and put a ureteric catheter by side of the stone. So the creatine settled down to 1.7 immediately, and this patient was admitted. So we did the PCNL for this right side today morning at 10 o'clock. So I'm showing you the video recorded at 10 o'clock in the morning. So now this is our position. So we have two bolsters. One is below the chest and one is below the hips, and the belly falls down. The patient is under spinal anesthesia. So as I showed you, the CM image I'm seeing on the monitor on the foot end, and the endo will go on the right side. So we use a disposable grape and for every patient so that doesn't spoil my theater. The water will fall in the funnel to the bucket. This is the iliac crest. This is the lateral border of the paraspinal muscles, the 12th rib, the 11th rib, and this here is the posterior axillary line.
The voice audible, recorded voice audible.
And this is my area of puncture.
Is the
Audible,
recorded voice
audible, audible.
Contrast, please.
You are putting contrast from below.
Stop. This is my puncture line. This is my calyx going to be of entry. It gives me a straight line to the pelvis. You can see the stone as a radiolucent filling defect. And so this is how I'm going to mark the puncture. So when I'm going to mark the puncture, it is very important that my needle, entry point, pelvis and PUJ has to be all in a straight line. And you can see this, it's going there right here into the straight line. So this is how, okay. So now I'm going to go here in the posterior axillary line. It's an intercostal puncture between the 11th and 12th rib, but in the posterior axillary line.
So I answered your point here, Chandramohan. Now, if you project the needle forward, it is all in a straight line. That is the most important point of planning the.
Don't mind it at all. It's way away from the pleural reflection. Okay. So can we stop the C-arm till I mark the puncture point? ये वाली light on करो.
Sir, stop it a minute.
Yeah.
How do you decide the lateral entry point? You are going triangulation. Approximately how lateral you have decided?
I always go by the triangulation method. I am not a bullseye person. So I always go just above the posterior axillary line. Just above the posterior
Okay,
axillary
answer
line.
is over. So if you keep a needle in the direction of the calyx, you select a point just above the, preferably around the posterior axillary line. Just above.
Correct.
Okay, sir. Go ahead.
In this
Sir.
case, we are between.
You have given a
In
skin
this
knee
case, we are
puncture.
between. Yeah. And in this case, we are between the 11th and 12th rib.
Okay. Even though it is lower calyx.
Yeah. So now is the most
Okay.
important
So
part.
can I have the C-arm please now?
So in 0 degree or puncturing.
So now I'm going in the.
This is
You are
the
moving
puncture.
front and back.
No, it was shown in the next frame. This is in 0 degree. We puncture in 0 degree and confirm in 30 degree.
Okay.
Now it's very important that can I have the room camera zoom out? Zoom out. I want you to show the C-arm in 0 position. Yeah, okay. So now can you zoom in again? Zoom in, zoom in. Perfect. So now my C-arm is in 0 degree position. Now I'm going in. Can I have my C-arm please? Yeah. Okay. On please fluoroscopy. I go in. Now I'm seeing the kidneys juggling. Okay. So I'm going in,
Yes.
going in, going in, going in, adjusting in 3 degree. And I get a jug give way. Okay.
So
So
you
now I'm
are
going to
holding the
oblique. So can you zoom out please?
Yes, Chandramohan. Yeah.
you are holding the needle very lightly. You are moving 1 to 2 degrees inside towards the kidney, and your direction is not grossly changed. Depth assessment you have done with your experience.
So yeah, to the point, depth experience comes very truly. You said depth experience comes with experience. Sometimes it becomes very difficult, especially in obese patients. You tend to get lost. So there's no problem. There's no problem. You always adjust in the posterior and see. But once if you are close to the kidney and you start hitting the kidney, the capsule of the kidney around the kidney will start moving. It will start
Yes.
buckling.
Okay.
That will give you, yes, I am now close to the kidney and I
Okay.
need to follow the kidney's movements.
Okay. Now, important point is you are going with some amount of the angle with the skin. You selected mid-axillary line. There is a point at least for that. But for a beginner, the angle which you kept is perfect angle. This is what intrinsic PCNL skill. Some people don't have it, some people have it. So once you go and move the kidney and in the direction of the calyx, if you keep, if the person is not experienced, you have to see in 30 degree. That are you going to explain now?
I am going to show the 30 degree view.
Please show that. Please show that.
So now, Chandramohan, you said a very important point. My concept, which I've learned from Dr. Mahesh Desai and Dr. Sabnis sir, is that never in PCNL you should have too much of an angulation.
Yes.
We always think it is a puncture which only bleeds. No, the puncture bleeds if it is a bad puncture, no doubt. But if it is a very oblique tract and you are angulating too much, you will tear the infundibuli. You will
Yes.
tear the infundibuli and you will cause bleeding. So it is important that you should be as possible parallel to the surface of the kidney or parallel to the angle of the kidney, and
Okay.
not too much like this and not too much like this.
Yes, yes, yes. Right, proceed, sir.
Zoom out. Yeah, show me the obliques.
Now
Move the CM in oblique.
oblique. Now we see the oblique here.
30 degree from
This
top towards
oblique
me.
we are not able to see. Yes. See, this is
Okay,
30 degree
can you show me
tilt
the
towards the surgeon.
Get in towards me. No. Show it in oblique. Okay, now move the CM slightly towards me. थोड़ा अंदर ले आओ CM मेरी तरफ बस. Okay, so I may be slightly posterior because my needle is just towards the end of the calyx. So I'm going to.
So are you seeing the tip of the needle?
Yes, yes. I am seeing the tip of needle in the system. It's largely dilated. But why you said it may be outside because it is posterior? Why you said that?
I said, if you see the calyx, it seems to be in the calyx, but it is towards the spine. So when you go towards the spine, that means you may be slightly posterior to the kidney.
That's
If you are
all.
away from the spine,
Stay back. Here is the most important point you told. Very, very important point. Sir, even though Dr. Kukreja sir has pointed out very important point, even though the needle is in the PCS, it is going towards the spine, means it is more posterior, means you are superficial. You can,
Correct.
once you try removing the needle, if it is not there, you will readjust more towards anterior because the needle has gone towards the spine. One thing, if you remember, lifelong same thing, if the needle goes towards the spine, you are superficial to your body, to your needle, or posterior in terms of signs. Thank you, sir. Very important point you told. Okay.
so if your needle is between the calyx and the spine, your needle is posterior, you need to maneuver anteriorly.
Yes.
If the calyx is between your needle and spine, that means you are anterior and you need to go posterior. So this
So
is just two statements you need to remember.
Yeah. Needle towards the
Now we are
spine,
seeing the
posterior,
CM
needle away from the spine, anterior. Right, sir. Right.
Correct. That is better simple.
Withdraw this. Can I zoom in, please? Can you zoom in?
Confirming whether I am in or no.
Zoom the room camera in. Zoom it in room camera. Zoom करो और अंदर zoom करो. Needle दिखाओ अच्छे से. हाँ, perfect. नीचे से सलाइन डालने के लिए कोई तैयार है ना? There, my puncture.
That's all.
So, चंद्रमोहन सेठ की सर 2, 3, 4 पंक्चर लगने दो, लेकिन आज दिन अच्छा था, फर्स्ट पंक्चर में हो गया, लेकिन कभी कभी 10 भी लग जाते हैं.
वो 10 वाला वीडियो हम देखना चाहते हैं.
सियाम को सीधा कर दो, स्ट्रेट सियाम, पुश सलाइन फ्रॉम बिलो, जूम आउट, जूम आउट, जूम आउट, जूम आउट. Yeah, so my assistant has gone that side and he's pushing from the ureteric saline. And now you can see, zoom in, again zoom in, zoom in, fast, zoom in. हाँ, correct. Now you see this, थोड़ा अंदर लो, कैमरा को थोड़ा, रूम कैमरा को थोड़ा फोकस करो मेरी तरफ, इस तरफ, correct. So that is the first important crucial step of a PCNL, getting a correct puncture. Now can I have the wire? राकेश आप अब इधर से आ जाओ.
The rest of the video, we have to quickly move it, and it's already 20 minutes over, so we will give only 5 minutes now time for you.
Okay. If I will do the wire step, then I'll go to the final step where I want to show how to proper puncture.
सियाम को आपकी तरफ.
What, which CM you are using?
आपकी तरफ लीजिए
Using
सियाम.
the Ellingers.
Which guide wire you use?
I'm getting a
The Terumo
Terumo wire
wire.
in.
I always use Terumo wire.
There. The wire is gone. So I told you, now this is how it should be. Puncture perfect, clear urine, wire walking straight into the ureter without the need of any manipulation. So I can go into the PUJ, I can go into the lower calyx, and the stone has already moved, you can see. So this is how it should go. The wire has gone in, and now once the wire has gone in sufficiently, parked in very well, I am going to withdraw the needle. There. Now this I want to show to everybody, all the postgraduates who are using. Now the toughest part of the dilatation is the lumbodorsal fascia, where your wire tends to get kinked generally. So this is a Cook fascia incising needle, and it is a cruciate shaped needle, and I am going to pass it over the wire. It goes over the wire right from here. And now can I show the C-arm please? Show me the C-arm.
This is a new thing.
It goes on the wire. I can feel the lumbodorsal fascia there, and it's cut. So I'm not going to the kidney. ये करके I'm taking out. So my dilatation will not kink the wire now at all. Can I have my screw dilator please? Yeah. So my next step is the screw dilator before the mini perk. C-arm please. Fluoroscopy.
Very nice. This is a very good one which you have shown previously. I didn't know that.
Rotating movements.
I have
All
learned
rotating
that.
movements only. No thrusting movements.
Yeah, very
Pronation
good.
and supination. There, give way, and I'm into the calyx. No need to dilate beyond the calyx. Zoom out, please. Zoom out, zoom out. Yeah, correct.
Are you using cell phone or handycam?
I'll push saline from here again.
My wife.
Okay, so this is the dilatation. Zoom in again. Zoom in again. Here, show the tip of the screw dilator.
iPhone 12 Pro Max. 13 Pro Max.
उसको थोड़ा मेरी तरफ लो आप. और मेरी तरफ.
This is again very important.
हाँ,
Whenever you
correct.
dilate, it
अब मैं ये
keep
saline
coming,
डाल रहा हूँ.
it indicates that your dilator is in the PCNL.
So
Very
you can
good
see
point
the
again.
urine coming from here. That means I'm well in the kidney, and it's been a relatively traumatic dilatation. So now I take out the dilator.
Started,
Can I have my sheet
started
please?
planning the puncture. It was 0 minutes.
Zoom up, ग्लव्स पहने हैं, पानी डालते रहो नीचे सर. Zoom out कर दो, थोड़ा zoom out करिए. So now this is my metal. Zoom in. This is my Store's metal sheath. This is a 16.5 by 18. When we talk 16 by 5, it is 16.5 inner diameter, 18 outer. Fluoroscopy please.
So we don't need high funda cameras, high funda systems, simple cell phone and good. Who has recorded, sir?
So again you see it's only gentle
My wife has
rotating
recorded
movements.
the entire video.
Very good. So a good understanding person who can record is very good. Kukreja's wife, so very nicely recorded. This will be a memory for anybody. Simple PCNL.
Visiting the Siam monitor so that we can see
my
both the
sheet
views.
going.
Both Siam as well as the hand are nicely seen, well planned. Siam, there is no need to show the Siam head. Why unnecessarily Siam? It is 0 degree.
That is 0 degree. Everything is 0 degree.
Yeah. Now you are retaining the guide wire and saline is flushed. Patient is slightly barking.
So now you see clear urine coming.
So
Yes.
you see the efflux of the water, clear urine. Okay.
Now I'll see.
Can you show the
Now see
timer
the timer.
please? So it's 8 minutes since we started deciding the puncture point, and we are in the kidney with the sheath in within 8 minutes. Can I have my nephroscope please now?
At this stage, do you try to remove the guide wire or you don't want to remove guide wire?
Focus करिए इसके ऊपर.
It is mandatory. I have to remove the guide
Zoom in.
wire in the paper. I will remove the wire.
That is the only risk factor in mini perk.
Are you able to read
So
this?
otherwise, you should use small nephroscope, go inside, see, and then remove the guide wire.
This is the mini perk Karl Stroh's
Correct.
sheath.
Correct. So always
This is a
see the
16.5 by
and for
17.5.
beginners,
Now you
always
can
have a
read it
safety
there.
wire.
Is it
For
clearly
beginners,
seen?
always have a safety wire.
16.5, 17.5.
So only with
So this
experience
is
that you
what
can
has gone in now,
bypass.
correct? And push saline from it, then push
Better
saline.
see the system and remove the guide wire.
It indicates a non-traumatic or relatively traumatic dilatation. And
This is the only disadvantage of Karlstad mini perk. The scope doesn't go freely without removing guide wire, or you have to thread over the guide wire.
Correct. Correct. Absolutely correct.
Fast forward a little bit, sir.
Then a fast forward sir.
That's important part. Fast forward.
कर दो.
Yeah. Now show the endo view.
बताओ सियाम.
Very nice. Your endo view as well as CM view are on the same screen.
So now, this is important point what I'm showing you.
Stop. So 26 minutes exactly. Recording stop. Just try and put the scope in every sheet. Lower calyx.
You have removed the stone. Just show how you have done laser lithotripsy quickly in 1 minute. Because our aim is only puncture today.
Every sheet. Lower calyx.
No, no, no.
1 minute, I'm showing you.
Bas, stop. Play. Play button. That is a trick here. Just press on the video. Click on the video, that's all.
बताओ सियाम. ऊपर आ जाओ.
This is 1 minute. It has again gone back.
Don't go to that. We are getting. No, 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 no. Sorry, I disturbed you because puncture was the only aim. You are getting.
The issue just having a modular OT HEPA filter doesn't make sense if you don't follow these minor steps. Can I have a gauze piece? Sir?
Okay, don't do anything, sir, now. Remove your hand.
उसको 2 को 1.5 करना जोड़ उसको.
This is thulium fiber laser.
I'll show you the settings also. These are helium fiber laser.
ठीक है.
You use laser always?
Can you please show the TFL fiber settings?
You use laser always?
Always, mini-pop is always laser, no lithoblast. Setting. This is the TFL, those are settings which I am using fragmentation mode. 15, 1.5 in 10.
सर इस कैमरा पे फोकस करो. जब तक आप बीच में कभी भी कर लेना. मैं बात कर रहा हूँ. वॉल्यूम ऑन. लेजर ऑन.
Don't do anything. Let us watch completely and
So
we'll
a little bit about this patient. This
Yes, sir.
patient had presented to us around 3 days back with a creatine of 5.8 and potassium of 5.8. So he had multiple lower ureteric stones on the left side and an impacted PUJ on the right side. PUJ calculus. This is the one which is there. So what we did a direct ureteroscopy and cleared the left side ureteric stone, which is very small, and put a stent. And on this side, we just managed to push the stone up and we put a ureteric catheter. So the creatine within 24 hours settled to 1.8. Now can you focus on the room camera here? आप यहाँ focus करेंगे इधर. Yeah. Okay. Get in close. Yeah. Now I want to show you how this mini perk thing works. I'm not using any forceps, and with the whirlpool effect, all the stone fragments are going to come out. I'll show you exactly how it is working. जरूरत नहीं पड़ेगी लेजर की.
That's all. So you are going in the direction of the stone.
Move the sheet.
Moving the access sheet towards
against
it.
the
Coming
calcium.
out.
Don't let the fragments slip out.
Tap
Keep
the
moving
stone
the sheet
against the
little bit here
glacial
and there.
wall, go in and just withdraw. Now see, all these stones have come out.
थोड़ा पानी डालो.
Correct.
All the stones have come out. I have not used any forceps or any baskets.
Okay.
Now this I want to show you, the stone has been cleared. Now this video is there to show how important a proper puncture is. Now you see at the end, I am showing you how we can access all the calluses. Just
बताओ
see the
सियाम.
video now. We have placed
ऊपर
the
आ जाओ.
stent. I did not show you all the steps of the stenting. now you see I've withdrawn my stroke. It is absolutely at the edge of
अंदर
the
लो मेरी
calyx.
तरफ, थोड़ा ऊपर.
It is not free.
All
It is
clear.
absolutely a traumatic puncture.
We'll just try and put the scope in every sheath. Lower calyx. This is a dye in the upper calyx. I've gone into the upper calyx. This is the upper calyx. Upper anterior calyx. So I'm showing you with the mini perk, the upper anterior, the upper posterior, or the medial and the lateral.
This is the advantage of small scope.
Then the lower. Here is the lower calyx again. All this gravel will wash out, and in the PUJ. So now you see this is how the puncture should be. You can approach every calyx from here and get into the PUJ. And now I'll show you how traumatic this puncture has been. I'm pulling out. You can see the papilla. Is there any bleeding? There's no bleeding at all. I'm out of the kidney now. Are you seeing this? Recording चल रहा है?
Yeah.
हाँ. Now I'm pulling out, out.
Okay. Thank you, sir.
And put the tape in
We
every
will close the
sheath.
screen because our idea is to keep it less than 30 minutes. It's a wonderful video. It will be there. This is a simple, straightforward PCNL, but well demonstrated with all the basic points. Can be replicated to any case. And next time you also record, because after 3 to 6 months I may ask you again, you also record staghorn puncture and dilatation. That is a little different where initial bleeding will be there. So one question is asked by Rami Boloma. Do you try to identify posterior calyx for puncture or go through the most peripheral one? Already you have answered in the beginning only. Once again you answer.
Every calyx from here.
Most
And get
preferred
into the PUJ.
lateral
And
puncture.
now I'll
Most
show you how
preferred calyx.
traumatic
That is
this
my
Sir, you stop the video in your laptop.
There's no bleeding at all. I'm out of the kidney now.
Okay, I've put the audio. Am I
Audio
audible?
down. Yeah. Now you speak. Do you go for peripheral or you go for posterior?
Peripheral.
Okay. In middle calyx, you may need to go posterior.
Middle calyx, if you see the anatomy, Sampaio's anatomy, it is the posterior and the anterior orientation is classically in the middle calyxal group. The upper calyx is always lateral and medial, and the lower calyx may be either lower lateral medial or anterior posterior. So if you are going to go by the classical definition of posterior calyx, it is generally the middle calyxal group.
Yeah. Next question is Sujan Makaju Shrestha, maybe from Nepal. Do you use any irrigation system?
No,
Yeah.
I don't use any. I used to use initially, but I don't use irrigation system at all because you may use undue pressure, and if you use undue pressure, it may raise the intracranial pelvic pressure.
That means you use
and
by
whatever
gravity. You use by gravity. Is it
normal irrigation by
TUR set or IV? TUR set or IV set?
TUR set.
Yeah. TUR set flow is better. It is also gravity irrigation system, but better.
Yeah, better and gravity irrigation. Yeah.
Thank you very much, sir. Because after prolonging 30 minutes, many people are disappearing. Even then, 200 people have watched this program live, and I am sure by tomorrow, nearly 1,000 people will see. Day after tomorrow, 2,000 will see. We think that these are all simple, but for all the juniors, every day is a learning. Those who have not done single time, this video is very, very, very useful. Siddhalinga Swami is asking, which is the best puncture needle, sir? I mean, what needle you use?
I use the Bard or the Cook. You can use a 2-part or the 3-part needle, your choice. Normally, we all use now the 2-part needle. So either from initial puncture needle, it comes from that PBN company is there, Bard is there, Cook is there, whatever your choice. It's a 17.5 gauge needle, and I use a 2-part needle.
2-part needle Cook I use. So Cook and Bard are the commonest used, and local people also will make, but they are little rough, and I feel little short length also. If you have little length more and smooth needle, you feel comfortable. Not as very thick
Correct.
needle.
Yeah, correct.
So thank you very much, sir. If you have not joined Pure Kukreja, sir, you also join, and all the juniors, you make your friends to join Pure. If you click Pure Urology, link will automatically come. This is only for urologists, only for urologist and only for urologist. Thank you very much. Let us try this module. Very short techniques, weekly ones are like that, so that those who are in remote areas who cannot attend conferences, almost Kukreja sir, this was like a live, very nicely recorded, exactly like live. We need not go for high funda cameras transmission. This is a what is your opinion this way of giving teaching to the juniors? Are you happy to this mode?
Excellent sort of teaching, Chandramohan, and this is what is required. Just small steps, which are
Yes.
very important.
Yes, yes.
So this video I was showing, this last video I have saved this video. It was done around a year back. But what important point in this is, if you see, is that the bowel shadow is there, correct? The white. So now when you puncture and when the kidney is moving, make sure that the bowel shadow does not move. That if the bowel shadow is moving, then you may be very close to the bowel. So I just saved this video only to show you this separate point. That
So-
in case you see the bowel gas should not move with your needle.
You wanted to show that old video now?
Oh, that's it. I should.
That-
The video is already going on now.
Okay, right.
Okay.
Thank you very much, sir. We will close the session. One more question from Sandeep Vadigiri. If there is no scope for intervention radiology attempting PCNL is okay, or should we rethink? If there is no scope for intervention radio attempting PCNL is okay. I don't know. It may not be a relevant question for PCNL puncture. He is asking maybe interventional radiologist. In India, I don't think anybody uses interventional radiologist. Urologist is the best. What is your opinion, sir?
Of course, it's purely a urologist domain. The puncture should be always the urologist.
Because we know the anatomy better. We know intricacies of going inside and moving. As you said, every calyx you could go, because you are peripheral, you are superficial. Both in this case, you are slightly posterior, you are most peripheral. So you could go to upper calyx anterior also. That is really appreciated, because the small scope, because of the peripheral puncture, because of the maneuverability, because of the skill. So no radiologist, better to be by urologist.
Every puncture should be by the urologist. Every urologist should have an access to a sonography machine in his OPD, so that he does
Yes.
it himself and sees himself. Yes.
Thank you, sir. Kukreja, sir. Thank you very much. We will conclude the session.
Thank you, Chandramohan. Thank you very much. Pleasure. Thank you.
Thank you. Thank you. Thank you, sir.